Before I get to that, I do want to remind everyone that we are accepting donations again. We hope that you've enjoyed the day today, that you've learned a great deal. You're going to take a great deal of information home with you, that it's helped. We obviously do still have a question and answer period, and Dr. Elmer, unfortunately, not here. Dr. Andrzejewski had to leave, but we have Dr. Robert Plunkett who's going to be here, and he can answer questions about the DBS. But anyone who would like to make a donation, it would be greatly, greatly appreciated. You're not just helping offset the costs for what we're doing here today, but you're also helping with our support group network, which is growing. You're helping us put the programming out that's therapeutic, exercise, educational, many multifaceted programs we're putting together, and that helps a tremendous amount. We do have donation envelopes on the tables. There are some near the basket and back. You don't necessarily need to use an envelope, but if you'd like to, please do. I just want to also mention that we have the evaluations. Everyone should have one at their place setting. We would encourage you, please, to fill those out. Let us know how we're doing. Let us know what your thoughts were about today. If you have anything that you want to express, be it about the lunch, about the seating, about the room, about the topics, whatever it may be, feel free to use the back of the sheet to write some notes for us. I guarantee you that we do actually look at each and every one of them, and we read them, and we do take them to heart. So that's very helpful to us. A reminder also that our mailing list is available on our information table outside. Anyone who would like to be on the mailing list to receive our quarterly newsletter, please do so. Again, about every week to 10 days, we try to send out an electronic update, an email with pertinent information. So if you'd like to receive those, we would love to have your information and be able to add you to that list. So on to that final quote, and this one goes, "Optimism is the faith that leads to achievement, and nothing can be done without hope." And that comes from Helen Keller. I think that's very fitting for the end of the day. As I say, we're going to open the floor now to questions for our esteemed panel. We do have a couple of microphones. We'll work through the room. I think that, once again, we owe a round of applause, not just to you who made the effort to be here, but again, for all the mothers that are in the audience. Happy Mother's Day. So again, any questions, feel free to put your hands up. We'll come around the room with the microphones, and we'll get to you as soon as we can. Oh, you have one there, though, right? Okay. I think we may have to pass that one along.
Okay, anyone can answer this. I like to exercise a lot because I want to keep my level of carbidopa-levodopa at a minimum. So is there really a benefit to just trying to take as little as possible by exercising, like boxing, biking, what do I do? Swim, walk, whatever. But I guess in my mind, I'm thinking if I keep that carbidopa-levodopa really at a minimum, that I'm going to have less problems later on. Or maybe I can keep it in my back pocket for when I really need it.
Anyone? A levodopa question?
Thanks for the question.
Right back
So a lot of specifics that patients have about how to manage their medicine, like you heard Dr. Elmer say, everybody with Parkinson's is different. So as a generality, this is a common thing that I hear from patients all the time. You know, I want to save my medicine for when I really, really need it. And I understand that philosophy, but you want to take just the right amount of medication for you. And that's a moving target. So taking too little and suffering and having disability that interferes with your ability to exercise or work or shop or do all your activities, you're not doing yourself any favors. On the flip side, taking too much medication isn't good either. So you really need to talk to your doctor to find the right amount. Not sure who your doctor is.
Hang on to that one. That way we've got two up there.
Chris, we have one here.
Go ahead.
Do any of you know if there are any resources available to help families secure aids for Parkinson's patients who need practically total care?
Okay, finding aids is tough. Finding reliable aids is even tougher. There are a number of organizations out there that have home caregivers. Those caregivers are CNAs, certified nursing assistants, so they have been trained. You can go there, put out word of mouth for people as well. You might find that even better. And I would also, for some of you that need respite care, contact the Alzheimer's Association, because I know they have a grant and they look more for respite care people. They're trying to expand it with a grant that came from New York State. It's not easy finding help at home. There is a shortage, there is a crisis. If you go to any nursing home right now, the turnaround rate at most of these nursing homes for aids is 40% a year. We don't have enough aids out there.
Also a big issue for a family who can't afford much.
Try the Alzheimer's Association and their grant.
Thank you.
Question here.
I've heard a lot about this TheraCycle. What exactly and what kind of benefits does the TheraCycle give you? I know it's a stationary bike, a form. You're supposed to speed up your pedaling and then let it go at a normal pace and then go again. And it's supposed to give you some kind of benefit. Has that been checked out at all by anybody? Called a TheraCycle?
Yeah, the TheraCycle is based on the tandem bike studies out of Cleveland Clinic. So what they found is similar to research that they did in individuals with stroke. It's a force-use paradigm, so it's not just a stationary bike, it's a motorized stationary bike, and it forces you to pedal at a certain rate to try to get your aerobic capacity up and improve the cardiovascular system, which also has an effect on the circulation then to the brain. So it's a force-use paradigm to improve circulation to the brain and force you to exercise at a certain rate, which has been shown to be beneficial.
Nothing that would really help you considerably with this. It's sort of like any form of exercise then, as long as you're doing some kind of exercise?
As long as you exercise intense exercise.
Intense exercise. Thank you.
Go ahead.
I was interested in the research part of the program. Dr. Elmer was talking about the alpha-synuclein protein compound that's promoted by the acrolein protein. The alpha-synuclein protein, which was promoted by the compound acrolein, I believe. And I was wondering if there's other compounds that would cause the Parkinson's that we're not familiar with yet. Also, I was wondering about the inhalation therapy, the puffer.
Answer those questions? There we go, it's working. So alpha-synuclein is the focus of a lot of clinical trials and a lot of research interests to try and clear the brain of this abnormal protein that we believe is the cause of the progressive cell death. And so there's a lot of different strategies that are being undertaken. Several have to do with antibody therapies, vaccination therapies to try and get your immune system to clear those toxic proteins from the brain. There's other avenues looking at small molecules to try and rev up your brain's natural ability to clear these abnormal proteins. So that is a focus for sure, is trying to clear alpha-synuclein. Exactly what the best and most effective and safest way to do that, we just don't know at this stage. And then the second part of your question was about the inhalation therapy, I believe, right? Maybe you're talking about inhaled levodopa. And so that's in the final stages of clinical trials right now. The preliminary data look encouraging as a rescue therapy. And so it's an inhaled kind of aerosolized form of levodopa, and then it gets absorbed through your lungs. Like Dr. Elmer was saying, a big problem is that the gut, these pills can get stuck in the stomach. They don't get into the intestine when you take oral levodopa, Sinemet, and so it doesn't get into your bloodstream fast enough, and that's one of the reasons that people have these on-off fluctuations. And so the inhaled levodopa is something that a lot of us are excited about. We were hoping that it gets approved and looking forward to using it in our patients as a rescue therapy. So if they have a failed dose and their dose of oral levodopa doesn't work as well as they'd like, they could, as we say, take a hit of the puffer of levodopa. But it's not available yet. It's still in the final stages of investigation, and I don't believe it's even been sent to the FDA to get approval. Once the company sends it, then it takes 10 months before the FDA renders a decision, and then it's several months after that before it actually gets available in pharmacies. So I'd say it's at least a year away.
Are you done? To do.
Parkinson, either in diagnosis or any role at all. SPECT imaging.
Right. So there is a FDA-approved imaging study called the DAT scan, capital D-A-T, and that's a type of a SPECT scan. It's a radionuclide scan. We do not use that to diagnose Parkinson's. Parkinson's is a clinical diagnosis based on the symptoms, but the scan is approved to distinguish two different kinds of tremor, Parkinson's tremor versus essential tremor. It's used quite a bit in research studies because if somebody has a normal DAT scan, but they have tremor, we're pretty confident, at least right then, that that tremor is not from Parkinson's disease. It's from something else, and sometimes doctors like us, movement disorder specialists, gets fooled. A patient really looks like they have Parkinson's early on, and if often it's they're being enrolled into a clinical trial, and we do a DAT scan, and we're shocked that their DAT scan is normal. Sometimes some of those patients go on to convert and have an abnormal DAT scan, and so they eventually kind of declare themselves as having Parkinson's. But in clinical practice, we don't use the DAT scan to diagnose Parkinson's.
Just to add one point to that, there have been a couple of occasions I've used the DAT scan to demonstrate to a patient that they do in fact have Parkinson's disease when they've not accepted the clinical diagnosis. And as you all know, it can take a long time to come around to the idea of accepting the idea that you have Parkinson's disease, sometimes even when the doctor's pretty confident that that's what it is. So this is the one test you can do to confirm that.
I just have a question for one of our group members from our support group. He's not here today, but I promised I would ask. Have you ever seen a connection with stuttering behavior and then Parkinson's disease coming later after someone's developing stuttering?
Oh, we're all saying no. We haven't seen that.
When you talked about the gastroparesis, and you said that the United States doesn't have a pill for that, but Canada does, is there a reason that we don't have it? Or is there anything that we can use in between? Like, my sister's on the omeprazole. Is it really helping, or are you just on it? And, you know, she seems to be belching a lot more and wonders, can she take the Gas X? Or how can you feel better? And we're all waiting. Why is the United States behind Canada?
Yeah, so that kind of has to do with the marketing. So the name of that drug was domperidone. Remember Dr. Elmo says it kind of sounds like the champagne? And that's not available in the U.S. I'm not sure exactly why. It probably has to do with dollars and cents, that companies don't see a patent opportunity, and so they don't investigate the dollars to get it FDA approved. It is approved in Canada. It does increase GI motility to an extent. I know I use it in my clinical practice. I have patients order it from Canada. The insurance does not cover it. So they have to like give their credit card number to the pharmacy in Canada, and then the pharmacy mails them the medication. I use it more for patients who have a lot of nausea from their medication side effect, because it usually is quite effective for taking away the nausea, but it's a bit of a hassle for patients to have to get it from Canada. But like I said, there is some evidence that can help with GI motility, so maybe help the pills get out of the stomach a little faster and get absorbed. I haven't really seen any good studies with domperidone for that particular reason. Well, you mentioned omeprazole, so that's Prilosec. So that's a totally different mechanism of action. And so that's for GERD, for the reflux disease, if you get heartburn after you eat. But that's not going to do anything for GI motility or for getting rid of nausea side effects from Parkinson's medicines. Belching? Right. Mm-hmm. Not sure about that.
Yes.
I don't know about that.
I have a question regarding non-motor challenges of Parkinson's. My son is 64 years old. He's been diagnosed maybe 3 or 4 years ago. The caregiver, I really would love to find someone here in a support group that's dealing with being a caregiver for 100 miles away. My son lives alone. He has no resources there as far as intimate relationships. But when he was home visiting last month, he said, "Mom, do they ever address the subject of what it takes to turn over in bed?" Now, he goes to a boxing class there, and he's met other people who've said, "Gee, we're learning so much here, but have they ever figured out how we turn over in bed?" Well, the first doctor that spoke said if he's having dreams during the night and he's fishing and he feels paralyzed when he first wakes up, I can't move. And then that passes, and then he starts to turn over in bed. And from what the first doctor said, he may have been in a dream doing other things, and when he wakes up, his muscles aren't responding. So, like, one question is, how do you address that?
I think that you might be talking about rigidity as a symptom.
He has rigidity. He does not have the tremors.
So what I mean to say is, though, a lot of times when we're trying to fish out rigidity symptoms, we ask, do you have difficulty turning in bed? So that might be part of it. If he's waking up out of sleep and temporarily paralyzed, he might also be experiencing sleep paralysis, which is a phenomenon. But those are two avenues that he could explore with his doctor.
Thank you.
The one other obvious thing, of course, is that, as Dr. Elmer mentioned, the overnight period is the time when your medication, the dopamine levels are at their lowest.
Yes.
So I don't know whether he takes a long-acting form of carbidopa, levodopa at bedtime or not, but that certainly might help. The other thing that I was taught when I was in my training program, which I've passed on to patients, is that sometimes satin sheets can help and just make it a little bit easier to roll over.
Mm-hmm. Thank you. And I want to say to Chris, he has been so helpful to me. He has spent many, many times talking to me, because the frustration is our wonderful support group meetings that we have here are great, but I haven't met anybody who's dealing with this long distance. So thank you, Chris.
Thank you.
What about stem cell therapy? Is there anything really going to come out of that?
So that's been under investigation for a long time, stem cell therapy, and there's reasons to be hopeful and there's reasons to be concerned. And so, when you're talking about stem cells, they're programmed to replace one particular kind of cell in the brain, and most of what you read about is the dopamine cells, and that potentially could help with the motor symptoms of Parkinson's, the stiffness, slowness, and tremor. But it's unlikely that replacing dopamine cells will do anything for a lot of the non-motor symptoms that Dr. Elmer talked about. So it's another strategy that perhaps could help address motor symptoms. We have a lot of strategies right now, medications, we've got surgical therapies like deep brain stimulation or Duopa therapy, and there's lots of other treatments that are being investigated to address the motor symptoms, one of which is stem cell. When people hear stem cell, they think, oh, that's the cure for Parkinson's. And so, it's hard to know what these clinical trials would show, but it's unlikely that just replacing one type of cell in the brain is going to address all these problems in that big iceberg that Dr. Elmer showed. It's probably just going to address the motor symptoms.
Thank you. Thank you so much. As Dr. Elmer mentioned pesticides 30 and 40 years ago that had the negative effects. Do those that are available today, are they any better than those that were available 30 and 40 years ago?
So it's not known if these are any better, because a lot of them just haven't been rigorously studied. But I could say the pesticides, any of the pesticides, have the potential to cause the same problems as some of the old pesticides that are no longer on the market.
Any other questions? Oh, question here. Sir?
Have you got any suggestions on how you can address restless leg syndromes when you first lay down in the evening?
So restless leg syndrome definitely is more common in patients with Parkinson's disease. There can be other causes of restless leg syndrome too. And one thing that we want to make sure we rule out in all patients is iron deficiency. Iron deficiency can be a primary cause of restless leg syndrome even if you don't have Parkinson's disease. Some people have talked about other kinds of deficiencies, including vitamin B12 and folate and other compounds, but iron is really the most important one to consider. And it doesn't need to be the kind of iron deficiency that causes anemia. So you may have a normal red cell count and you can still be iron deficient, so the doctor has to check your iron levels and the protein that binds iron, which is called ferritin. Then there can be other causes as well, like a peripheral neuropathy, the kind of thing you can have in diabetes and other conditions. And there can be people who have a family history of restless leg syndrome even without Parkinson's. But if you do have restless leg syndrome, there are a variety of different things that you can use to treat. And one of the drugs is the same kind of medication that often people with Parkinson's take for their Parkinson's disease, which is the group of drugs called the dopamine receptor agonists. And there are three of those. One is called pramipexole or Mirapex, one is ropinirole or Requip, and the third one is the rotigotine skin patch, which is Nupro. So all of those, the same drugs which you use for Parkinson's, you can use in a much lower dose in the evening to treat restless leg syndrome. Now you should take those drugs probably an hour or 2 hours before the onset of your restless legs, because it can take that long for the medication to start to take effect. It's not the only kind of drug which can be helpful. There are other drugs. One is called gabapentin. My colleague here is a big fan of gabapentin for lots of reasons. There's a longer-acting form of gabapentin called gabapentin anacarbal, which is brand name Horizont, which has also been approved for restless leg syndrome. And then there's some other choices that you have, but those are the two classes of drugs we tend to start off with. And occasionally people can have very severe forms of restless leg syndrome, which may require a combination of different medications. Some people even wind up taking an opioid, although we certainly don't start with that. So it can be a range from a thing which is just a nuisance to something which can be really very debilitating. And if that's the case, you need to be under the care of a doctor who really has got a lot of experience treating that.
Oh, we've got questions over here. Sure.
We have one here.
Okay, go ahead.
I've had quite a bit of trouble falling out of bed. I actually turn my back on the edge of the bed and have a nice tall mattress, and it's quite a fall in the middle of the night, 2 or 3 times. And my wife got me one of these bed rails, which folds down, goes out of the way, and it's relaxed me so much in bed. I can sleep without having to worry. And worrying was what I was doing, because I'd wind up going off that bed backwards, and 3 feet to the floor, and then boom. So if anybody's had any trouble, I'd like to hear. Is that normal for Parkinson's people?
Can I just ask, when you wound up on the floor, did you think you were waking up from a vivid dream or a nightmare?
No, I was sticking to the mattress so much, like having trouble turning over, that I rolled to get over. And when I rolled, I was at the edge of the bed and I could not get back. Because once you start over that backwards off that bed.
And did the kind of mattress matter? Because I think sometimes people who sleep on a softer mattress can have a lot more difficulty rolling over.
Well, the mattress I have now is so insensitive, wise. When I jump on it, it doesn't hurt my wife sleeping next to me, and it's helped me. But until I got that bed rail, and now I felt comfortable with sleeping and not being able to, because if I go up against that in the middle of the night, you can feel the rail. And but I was just wondering whether it was normal.
Well, I think it's interesting that you had the problem because it sounds like you kind of launch yourself to try to get yourself over into a different position, which is the reason you fall out of bed. I think more people would throw themselves out of bed if they have this condition we talked about before called REM sleep behavior disorder. But the solution would be the same, which would be you'd recommend a bed rail for those patients also, so you're doing the right thing.
For caregivers, that was a good suggestion with the bed rail. I suggest using two. Put a pillow on that bed rail and then put a pillowcase holding the pillow to the bed rail, because sometimes people slip through it and they can it's a safety issue of getting an arm caught or a leg caught. So if you put a pillow next to the bed rail and a pillowcase to hold it, it's just a little bit safer.
Hello, I'm Veronica Hogel, and I have a different question. I was diagnosed with Parkinson's in 2001. It was 18 years ago. And at the same time, I began to write. And I had terrific success. I was published in 3 countries. And I feel that the medication had something to do with it. Has there been any research on the medication and the side effects that, in my case, was very beneficial?
Could it be that the medication sparked her creativity?
Can we ask what medication she's on?
And it wasn't marijuana.
You first.
Do you know what medication it was?
Well, I take 4, Mirapex and the carbidopa, levodopa.
So thanks for sharing that with us. That's great to hear about something positive that came out as a side effect of medicine. Maybe, so I mean, there's all different ways to think about why you had creativity, but congratulations to you on your books. That's fantastic. Maybe the Parkinson's itself somehow sparked something inside of you that made you want to write, just that change and that realization. It's a possibility. It could be from the one medication that I think Dr. Lichter and I were both kind of nodding our heads is the Mirapex. So that pramipexole, Mirapex, the dopamine agonist, sometimes can have kind of strange and very problematic side effects, these impulse control disorders, where people become very compulsive. They can have compulsive gambling, compulsive shopping, compulsive eating, hypersexuality. But sometimes it can create some creativity kind of abilities. So I wonder if that was one of the first medicines that you were put on, the Mirapex, if maybe that's what sparked motivation. Maybe it just really motivated you to actually sit down and write these novels. So I think that's a possibility.
And she's being modest. This is J.K. Rowling.
Something else, I know a man who, same medication, he started playing piano. So you just don't know. Also, writing, there is a connection if you write by hand, that it really stimulates more of the creative juices than if you're at your computer. It's sending a signal to your brain through your arm and through the manipulation of that pen and your thought process. So when you're journaling or if you're doing any type of creative writing, it can be cathartic, which also makes you feel good. And there's other research going on right now with the art of writing. So keep on writing, and that's good information for caregivers as well as for patients.
And keep writing, absolutely. Thank you. Catherine's got a question?
I have violent nightmares. In fact, I had one this week where someone was trying to kill me, and I sat up a little and started punching. Should your bed partner try to wake you up, or just let you go through it?
I think it's okay for your bed partner to try to wake you up. I mean, the patients who have dream enactment behavior or REM behavior disorder, a lot of them have been shown to have dreams of aggression. And I think probably keeping safety as a number one is probably the best bet.
Hi, I had a question. I'm on Effexor, and I was looking online, and it says that causes Parkinson's symptoms. What's that? Do antidepressants, because they work in the brain, correct?
Yes, they work in the brain.
So could that have any correlation?
I think you must have maybe misread the side effects. That I'm not aware of
Well,
any
it was
of
2
the.
o'clock this morning that I was reading.
Oh, it was 2 o'clock this morning. Maybe it was that.
But it said.
No, it may have said, like, if you have Parkinson's, talk to your doctor, because there might be some interactions with Parkinson's medicines. But the antidepressants, like Effexor or the serotonin-specific medicines, don't cause Parkinson's.
We actually just had Irene Richard here in Buffalo on Thursday to give our last neurology grand round of the year to our faculty. She is a professor of neurology and psychiatry at the University of Rochester. I don't know whether anybody here is from Rochester today, but she did a very important NIH-funded trial of 2 medications for depression and Parkinson's disease a number of years ago. This was a multi-center placebo-controlled trial. So one drug was paroxetine or Paxil, and the other drug was venlafaxine, Effexor. And they were both shown to be very effective for depression and Parkinson's disease. I think what occasionally you can see with drugs like venlafaxine is a little bit of postural or action tremor in some patients, but it doesn't cause Parkinson. It doesn't cause depression or aggravate the Parkinsonism. In fact, it's beneficial for most patients.
I'm curious about a slow but steady weight loss. I ask because of reading about a study in Scotland concerning weight loss and morbidity.
So the concern is this is an ongoing thing? It's okay. What should she look out for with an ongoing steady weight loss? Anyone?
I mean, you can commonly see, some weight loss with Parkinson's disease, maybe 10 to 20 pounds, but if you're having an ongoing slow weight loss, there's probably something else going on. And I would have a talk with your primary care physician about other causes.
Just one other thing to add to that. Sometimes, so mood disorders are real common in Parkinson's, especially depression, and loss of appetite is a common symptom of depression. So sometimes an antidepressant medicine can really stimulate the appetite, stimulate the mood, and help a patient gain weight. Also constipation, if you're backed up, that will cause your appetite to go down. So make sure you're having regular bowel movements at least every other day.
Dr. Elmer also talked about the potential of dyskinesias to cause significant weight loss, so I don't know whether that could be a factor in this case. But weight loss does tend to, although I agree that should look into all other possible medical causes, including troubles with swallowing, because caloric intake can go down if you have any kind of degree of swallowing problems. Make sure that there's no hyperthyroidism and other medical problems. Obviously, you don't want to miss some kind of cancer. But having said all that, in patients with more advanced Parkinson's disease, weight loss is something you see a little later on in the course. people also talking earlier on about medical marijuana. Well, in New York State, the two conditions for which it has been approved in terms of indications, Parkinson's indications, is weight loss and pain. So even though if you see a doctor for medical marijuana for Parkinson's disease, they will consider, they'll consider you regardless of what the problem is that you have, and we're starting to learn that it may be helpful for tremor, may be helpful for sleep in individual patients. It can definitely help with weight loss if there is no other good way of treating that. Most people, though, if you start to put them on, high protein supplements, Ensure Boost or something of that kind, if there's no underlying swallowing problem, you can start to get a better control of weight if there's no other medical reason for it.
Yeah, I just want to respond to the gentleman that has the nightmares. I've always found my wife deals with that too, these vivid dreams, and that waking her up was always helpful. Besides her getting out of the dream, it made me feel like Superman. Okay, swooping in to save the day. So, so I think actually it's a good idea if they're having a vivid dream and it's not putting them in danger or putting the person waking you up in danger, is to go ahead and wake them up.
Thank you. That's cute.
I have a question regarding the effect of adrenaline, fatigue, and temperature. My two different, I have the essential and rest tremors. And even as I ask a question, I can sense, like public speaking used to be an easy thing as a teacher, but now I'm wondering, is that because of the total effect of the nervous system with the Parkinson's?
So you have a combination of essential tremor and Parkinson's tremor, is that right?
Thank you.
Yes. So, and you talked about the effects of adrenaline. I think adrenaline, stress, excitement, other emotional factors can aggravate both forms of tremor, both essential tremor and Parkinsonian tremor. And you talked about the way your own tremor might be amping up a little bit now just with a microphone in front of you. That kind of performance anxiety and performance tremor, like people who are public speakers or have to do something else in front of an audience, that often will quite prominently aggravate essential tremor or even bring out a normal degree of what we call benign physiological tremor, even people who don't have another reason for their tremor. And one of the medications for that is propranolol, which is a beta blocker, which does block the release, which does block the compound which is released by the adrenal gland in response to stressful situations, that fight or flight response. Beta blockers will help with that particular form of tremor in particular. Parkinsonian tremor we don't tend to treat with beta blockers, we tend to treat with other drugs. But in some patients where I see a combination of both forms of tremor, which is a smaller minority, I sometimes will add in a little bit of propranolol, and it can sometimes help. Fatigue, can aggravate a lot of different symptoms. And I'm sorry, the third situation was temperature. Yes. Well, the most common temperature is cold, and we get a lot of that in Buffalo. So I don't know what other temperature extremes you notice aggravate your tremor, but very commonly cold will do that.
Did you want to say something? Did you? No.
Well, thank you very much, folks, for coming out. Oh, was there more to say? I'm sorry.
This, your first speaker this morning mentioned shoulder pain. Will common exercises or physical therapy help that? Or if it's Parkinson's related, it doesn't make any difference?
Yeah, physical therapy will help with shoulder injuries, rotator cuff injuries. Parkinson's patients on the side that they're more affected are more likely to get rotator cuff tendinitis on that side. So proper adjustment of your Parkinson's medicine is real important for that, as well as physical therapy. When it gets really bad, if you get really bad rotator cuff injuries, then sometimes you need surgery for that. But physical therapy and maximizing your Parkinson's medicines often is a good 1-2 punch. Since we're talking about boxing.
Since we're talking about boxing, have you experienced the pain diminish through the boxing program?
We try to loosen them up with different exercises. One of the things we use are Indian clubs, and I don't know if you know what an Indian club is. It looks like a bowling pin, and we'll do different exercises with it and increase the rate of the range of motion as we're working them. Okay, there's a lot of different exercises you can do. What you want to do is be warmed up first, and then try to relax those muscles. The shoulders get tight, the back of the neck gets tight, and a lot of times we'll have a client with one shoulder that's tilted forward and lower or higher, and it seems to help it. We work a lot with that.
Well, thank you very much, everyone, again, for coming out. It was a great turnout. Thank you again to everybody on our panel, all of our experts, our speakers today. The evaluation forms, feel free to just leave them on your table. We'll pick those up. We will be doing this again next year. We look forward to seeing all of you again then. And again, thank you so much for coming out. We really appreciate it.